All right, everyone. So we'll go ahead and get started on chapter 19. This is over neurologic emergencies. This is, as I say almost every time, this is good stuff. I enjoy neurology, neuropathology, whatever. So we'll go ahead and get started. I think this will just be a one-part video, just a little bit on the longer side. There's jam-packed with some high-yield information in here, right? So just a real quick introduction. You'll notice sometimes your book will start with some epidemiology, and that's kind of what they're doing here, right? So like, stroke is the fifth leading cause of death in the United States. There's a lot of reasons for this. One of them is because we smoke, uncontrolled diabetes, hypertension, right? And I talk about those a lot because they cause vascular disease, and then that can lead to stroke. So, we're going to talk about exactly what stroke is. Maybe you've heard of this before, but like a real quick down and dirty example of a stroke is basically the heart attack of the brain, where usually, what we typically think of is hemiparalysis, where one side of their body will be paralyzed. But it can present in a lot of different ways, and we'll talk about what that looks like. But anyways, as opposed to seizure, which we tend to see these in the Walmart, right, where people are shaking, we tend to see these in public places. Seizures occur as a result of a recent or old head injury, brain tumor, metabolic problem, genetic disposition, scar tissue from a stroke, or an unknown cause, right? Idiopathic. So, the seizures seizures are almost like a sign and symptom of usually underlying pathology. And so that's, seizure actually is a sign. It's really not a pathology itself. It's a sign of, something else. So what's causing that, whether it's epilepsy or brain tumor, it gets really complicated. But we have to look at all the causes as differentials. And so that's why the diagnosis of seizure is usually left to a neurologist, because it's a complicated diagnosis. So, altered mental status is a common presentation. We get this a lot. I'd be willing to venture that more than half the patients we run have some form of altered mental status. So we see this a lot, and the reason we do is because it presents with a lot of medical problems, right? It could be heart related, it could be blood related, it could be lung related, it could be skin related, right? It could be infection related, right? So there's like so many ways that we can present reasons we can have altered mental status. So just be aware, like it's very broad. That this would also be a sign. So very broad diagnosis. So altered mental status reflex to protect an awake person may not function when the nervous system is depressed. And we've seen this, right? So if someone's overdosed with heroin or narcotics, we have to worry about them protecting their airway. Or if someone's having a stroke and now they have an altered mental status, we have to worry about them protecting their airway. If someone's drunk on alcohol, right? We have to worry about them being able to protect their airway. So we start worrying about like altered mental status because it can knock down the nervous system, or suppress it or depress the nervous system, to where we have to worry about them maintaining the cranial nerve reflexes to protect their airway. We'll talk about what that is, okay? So anyways, a real quick anatomy and physiology review. This is just showing some straight up division of the central nervous system. So basically, we'll kind of start right here, right? We can start here at the brain. At the brain and spinal cord. So the brain and spinal cord will send commands to the body to act, right? And so this happens in two different ways. The way that we talk about a lot in this class is something called the autonomic, like an automatic, like so it's done without thought. The autonomic nervous system, and so the parasympathetic nervous system. This is the rest and digest, or as they say, the feed or breed. That's fine, same thing. But this, the parasympathetic nervous system will have a lot to do with digestion, and the reason they're talking about feed or breed is the parasympathetic nervous system has to do with erection. Okay, I'll say that again. Parasympathetic nervous system is responsible for erection, and the reason we say that is because, like again, in neurogenic shock, you can see priapism, which is the medical word for erection, and the reason that is because you lack sympathetic tone. So anyways, we've talked about that again in shock. But anyways, the sympathetic nervous system, the fight or flight. I always give the example, if you have to fight a bear, right? What do you want? You want your lungs nice and the bronchioles nice and dilated. You want your heart rate to increase. You want your eyes to dilate to let all the light in. You want a bunch of muscle or blood flow going to your muscle, right? So this is the fight or flight system, right? So this is when you're getting ready to fight someone, you feel that adrenaline dump, okay? Now, the somatic nervous system, this is stuff that's underneath conscious control. So me talking, me moving my muscles, right? These are things that are done by command, okay? So the somatic nervous system is what controls voluntary muscle, okay? Now, we should know that information from inside and outside your body, that's sent up through the peripheral nervous system into the central nervous system, okay? And then you process information. I mean, that's kind of rudimentary. We should understand that by now. So, a test question, the brain and spinal cord, is it part of the central nervous system or the peripheral nervous system? It's the central nervous system. So the brain and the spinal cord, they're located centrally, right? Are part of the central nervous system. Now, notice I'm saying and the spinal cord. Now, the peripheral nervous system, these are going to be your peripheral nerves, okay? So the nerves down here in my fingers and up in my nose and in my ears, right? Well, not my ears, but those are all peripheral nerves, okay? Now, the brain itself, one thing that I want you to know about the brain is it's very soft. And so like if I were to take your brain, and I've told you this in lecture videos before, but I'll reiterate. If I were to take your brain out of your skull, non-preserved, like not in formaldehyde, and hold it, it would collapse on itself. It's very soft. So we have all these layers to protect it. And the skull and so it's important to realize because I think sometimes if you ever seen like a brain dissection or maybe like a dead animal's brain, especially after if they've been dead for a while, I think we think that it looks that it's firm. It's not. In a real human, it's not like that. So just be aware. Now, the brain, obviously, this is controls breathing, speech, memory, thought, executive function, all body functions, right? Come from the brain. And which part of the brain we're going to talk about on the next slide, but just some real general brain anatomy that you need to know. I mean, obviously the brain's very complex. I need you to know like these 5 things on this slide, okay? So the big chunk of the brain, when the layperson, you think of the brain, that's called the cerebrum, okay? That's this word right here, the cerebrum. The cerebrum, okay? It sounds very close to what I'm about to tell you something next. But the cerebrum is the majority part of your brain, right? And so, up here we have, emotion and thought processing and executive functioning, and we have speech over here, and we have motor function and sensory back here, and we have visual cortexes back here, right? So it's divided into pieces, and we know pretty well, so if we were to, like a lobotomy, right? If you were to stick an ice pick in someone's nose right here, you're going to change their behavior and their emotion. And so we know pretty generally where at each part of the brain, if you were to have what we call a lesion or like a boo-boo or a wound or a dysfunction or something like that, a lesion, right here we can predict, oh, you're going to have Broca's aphasia, or, you're going to have, you're not going to have sensation on the left side of the body, or whatever we come up with, right? So that's something to know too, that we not EMTs, but generally at the physician level, you'll know if someone's hurt here, what signs and symptoms would you expect, okay? So again, the biggest part of the brain, the majority of the brain, right? When we think of a brain, it's the cerebrum. Now, there's this very, very important structure called the cerebellum back here. The cerebellum. Notice it sounds similar to the cerebrum, but it's different. The cerebellum sits back here in the back of your skull, up underneath the brain. And the cerebellum is what's responsible for GPS of your body. So one way that I try to help students learn this is alcohol affects the cerebellar vermis, right? So when we get drunk, right, we drink too much alcohol, the cerebellum is what gets affected, namely, and that's what we see. Other systems are affected, but the cerebellum will get messed up. And so the cerebellum, being a GPS, tells my body right now, Hunter, your finger's right here in relation to your nose. And if you want to touch your nose, you need to bring it this close, right? And you could do this with your eyes closed. And there's a reason that cops do this, right? There's a reason that cops do standardized field sobriety tests, SFSTs, right? And they have you close your eye and lean your head back and do the finger to nose test, right? Because they're testing the GPS of your brain, the cerebellum, okay? And alcohol messes up the cerebellum temporarily. So, we see the same thing with the heel to toe test, right? If your brain does not know where your foot is in relation to the other foot in the ground, you're going to stumble. So that test becomes really hard if you're intoxicated. So these, when you think cerebellum, I want you to think this is the part of the brain that's the GPS that tells your body, oh yeah, your finger is here in relation to your nose, and your foot is here in relation to the ground and to the relation of your hips, and so it's a GPS that tells your body where your body parts are located at all times. There's a fancy word for that called proprioception, but that there's other pathologies where that get affected, but alcohol does it really well. And we've all seen someone who's drunk who's stumbling. It's because they don't know where their body is in relation to the rest of their body. Their GPS gets messed up. Okay. So the cerebellum, it's smaller and it sits back here in the back part of your skull. It's pretty close to your spinal cord. Speaking of the spinal cord, here's the spinal cord. So basically, all this information feeds its way to here, right? So all the brain has to make its way to a central area and it ends up meeting in the spinal cord. And the spinal cord is made up of namely three sections, right? The midbrain, the pons, and the medulla, right? And so they all have their own weird little functions and things that they do that isn't super important. But when you think brainstem, I want you to think this is the place that's essential for life. Respiration's controlled here. The essential life functions, really the big one as an EMT is respirations, are controlled in the brainstem, specifically the medulla, which is here. So just know that the brainstem is essential to life, and the brainstem will further condense, and it ends up into the spinal cord through the foramen magnum, and then out, to your peripheral nerves. So this is a two-way highway, by the way. So obviously your brain's sending information out and it's receiving information in at all times. So, don't always, it's not just sending information down. It also sends information back up. Okay. Now, again, the cerebellum, which one's the cerebellum? This guy, the small guy on the back, and has a different pattern. It controls your muscle and body coordination. So another example, like I play piano, right? So this kind of like is where we pre-program some things into our body to where you don't have to think very hard about doing something. So, they say that playing piano is good for the cerebellum because again, your GPS has to be really spot on if you're going to hit keys really fast and not really think about it, okay? But the cerebrum, you should know that it's divided into the left and right hemispheres. There's an actual fold that should be there that divides the two, called the corpus callosum, that divides the brain into a left and right hemisphere. So you do need to know these three things that are on the PowerPoint. These have been tested before, and they're very simple. And I've told you this. The front controls emotion and thought. If you've ever heard of the procedure back in the 40s, 50s, 60s called a lobectomy, they would stick an ice pick up into the nose, swirl it around, and destroy the frontal section of the brain. They would do this in like schizophrenic patients, bipolar patients, and you would destroy their thought and emotion, so they would just become zombies, like they'd be zonked out. And so that used to be rudimentary psychiatry, neurosurgery. So again, if you struggle to think like which one's thought and emotion, right? It's the one we did a lobectomy on in mentally ill patients, and it's the frontal lobe. The middle controls touch and movement. So this is where we get like a bunch of sensory information about feeling and where, and then we also send information out on what to do, like what we want our muscles to do. So there's the primary motor and sensory cortexes of the brain, and they're right here. These two, right? These two. Those are where we get like sensory and information. Okay. Sensory and motor information is sent in and out. Okay. And so the back process is sight. Okay. And I always think this is really weird because the eyes are obviously way up front. That means the optic nerve has to travel really far to get back to the primary visual cortex, right? And it's in the back of the brain. Okay. So very easy. Like those are threes that I need you to know. Okay. So we have these things. So I told you we send messages out through the spinal cord, and of course messages are coming back up through the spinal cord. It's a two-way highway, right? But we have these things called cranial nerves, and I don't think I put a picture in here, but you should know that we have some nerves that are jut off the brain that are not part of the spinal cord that kind of tell our face and mouth what to do, right? So like speaking and chewing and sensation and vision and hearing and taste and those are the big ones, are all come off of the cranial nerves. So we have 12 of them. You don't need to know exactly what they are. But we can, the reason this becomes important is we can sometimes use these in pathology, okay? And I'll explain that later on. But the rest of the nerves, with the exception of the cranial nerves, join in the spinal cord and exit the brain through the foramen magnum, okay? The cranial nerves jut off the brain stem. So, and then everything else juts off the spinal cord itself, like the spinal cord proper, right? So just be aware. And the hole, sometimes this is tested, the hole in the bottom of the skull right here that the spinal cord exits through is called the foramen magnum. Okay, foramen just means hole in Spanish. I'm not Spanish. In medical terminology, and magno means large, right? So big hole, and it's the big hole at the bottom of your skull, the basilar area of your skull that the spinal cord will go through. Okay. Now we should know that at each vertebra, right? Uh, there's well, really at the neck and really in the torso, and but yeah, we'll just say the neck for now. It juts off into two like spinal nerves, okay? And so the reason that they're saying this is you don't need to memorize, do not memorize dermatomes, but we have these things called dermatomes. And so basically, if you've ever been to the doctor and you've seen them, I don't have my reflex hammer in here, but kind of like bang your joints and have you kind of jerk, that's testing something else, but that's testing your spinal reflexes. But this we can test dermatomes on patients to see if their spinal or their sensation of their spinal cord is intact by just like kind of stroking certain areas of their body. Do you feel this? Do you feel this? Or you can take like something sharp and like, do you feel this? Do you feel this? Right? And you're trying to feel where sensation is present or absent. And so basically, like I'll give you an example like at the nipple line, which is T4, right? Right here. So basically, if someone feels just above the nipples, but I keep going down and they're like, no, I don't feel that anymore, you might think, oh, well, there's a lesion in the T3, T4 area, right? So there's something has happened to their sensory areas in their spinal cord or periphery or wherever that is causing lack of sensation in the T4 area. So sometimes we use that clinically in a hospital. You don't really use that as an EMT very often. Like I said, I don't think you need to memorize the specific dermatomes. Just know that dermatomes, like derma, skin, right? Dermatomes kind of give sensation to our skin, and so it allows us to feel within our skin, and we can use that clinically to know if someone can't feel here, like at the nipples, then there might be a lesion from there up. Okay, so that's what that's used for. Now, neurons obviously are so. Let me go to this one first. So neurons are composed of three different things, right? So there's the cell body, the axon, and dendrites, right? So this whole area right here is like the cell body, and this is the axon and the axon terminals, and these things right here that jut off are called dendrites. And so that's I'll say that one more time, right? Cell body, dendrites, goes down the axon terminal to the axon, right? Or down the axon to the axon terminals, excuse me. And so what's interesting is your brain has billions and billions of these, and everything that I'm saying right now, me staying alive, me processing how I'm going to teach you this material, is being sent through electrical impulses through my brain, which is just mind-boggling to think how quick this is working and how efficient this is. So this is the most basic level of human neuroanatomy, right? The neurons. And so we see neurons obviously in the brain. And so let's see what they say about them, right? So an interaction between two neurons is called a synapse. A synapse, okay? And so a synapse, as they say, is present wherever a nerve cell terminates. So sometimes synapses will go nerve to nerve. That happens a lot in the brain. But sometimes synapses will even go nerve to muscle, nerve to whatever. But typically it's nerve to nerve or nerve to muscle. Okay. And so most neurons and neurotransmitters to transmit their signal across the synapse to other neurons. So neurons can send, electricity one to the other. Okay. That does happen. But what we really start looking at is this synaptic cleft, like this area right here called the synapse, because this is where a lot of neurotransmitters like dopamine, GABA, opioids, right? They, cocaine, whatever you want to name, right? A lot of pharmacology plays a role right here in the synapse, and I just show this to you here, and I've showed you this before, I think, but this is just demonstrating like this is the axon and this is the axon terminal, right? And so what this just shows like the example that right in this particular example they're talking about amphetamines and cocaine and stuff like that, how they act on these synapses to have their desired pharmacological effects. So the reason this becomes a little bit relevant is there can of course be pathology here, right? Like botulism takes place here, tetanus takes place here, myasthenia gravis, Lambert-Eaton, right? There's a lot of pathology that takes place here that's debilitating. It's terrible. But more importantly, like overwhelming amount of pharmacology takes place, especially neuropharmacology, takes place here. So we use this concept of synapses and reuptake and stuff like that. We use it very seriously in neuropharmacology. Okay. So that's that. Remember, this whole thing made up is called a neuron. We have the cell body. Off the cell body, you have dendrites. These are little finger-like projections that will they help. Well, they do a lot of things, but they help also gather information. They gather stuff for the cell and neurotransmitters and stuff like that. Okay. They also help connect other cells. These are like kind of like long-reaching arms. Okay. And one thing, and so then we have axon. Now, a neural axon, a nerve axon, right? This little like highway, um, it can be very long. So of course they can be microscopic, and they are, but realize that sometimes, especially in peripheral nerves, they're very long. So that's just something to kind of point out. I always thought they were always microscopic, very, very small, and they are microscopic, but like they can be long in length. Okay. So there's many different, there's a lot of different disorders that will present with neurological symptoms, right? So the thing is, just like why I say shock, altered mental status is one of the first things you'll see, is because the brain is so sensitive to oxygen, glucose, temperature. And if you don't get blood that's delivering oxygen, glucose, and warm blood to the brain, then it's going to be one of the first ones to be like, yo, buddy, I'm not going to work because it's so dependent on glucose and oxygen that's carried in the blood. So that's why we see this, we see a lot of pathology, that relate to the brain. It's because I mean, again, a skin infection can end up throwing someone into shock or causing neurological dysfunction, and that actually happens a lot. So just be aware. Other brain disorders, could include infection like meningitis, encephalitis, and just straight up brain tumors like a mass occupying space, right? Neoplasms. Those can certainly cause altered mental status or brain pathology. So now we're getting to the good stuff. So let's just start talking about stroke. So the other word for stroke that I want you to know is called CVA, and that stands for cerebral. Remember cerebrum, right? Like the brain. So cerebral vascular accident. So if you hear me or someone called a CVA, right? It's called a cerebral vascular accident. That is the other word for a stroke. Okay. Stroke is a very broad term. Okay. It means a lot of things for the brain. It's not very specific. Okay. So a CVA or a stroke is interruption of blood flow to the brain that is sudden and results in loss of brain function. Okay, and I'm going to show you what this looks like. So I'll show it to you here. Let's just go here. So these are the carotids, right? And so what happens is if you have a clot, just like in the previous chapter, like a heart attack, right? If you have a blood clot that travels up here to the brain, or a thrombus, or a piece of fat, or whatever the story is, come up here to the brain and block off the highway, the area distal to the occlusion will die, right? So just like the heart, it will become ischemic. It'll be screaming and starving for oxygen, and then it will infarct. We know that the brain can only be ischemic for a few minutes. So if the brain's cut off with oxygen, it's going to be very ischemic for only a few minutes, and then it will infarct. And just like the heart, the brain does not regenerate ever in adults, right? So when this part of the brain dies because of a stroke, it's dead. It's not coming back. It just scars. So for example, in this particular area, this could very well be speech, right? So we could get Broca or Wernicke's aphasia. And so if you end up with the condition called aphasia, which is an issue with speech, after this stroke, their speech does not come back ever, okay? So that's the issue with stroke, and we're going to talk more about this, but I just wanted to show you a quick demonstration on that, okay? So remember, ischemia, only for a few minutes, will lead to infarction. When it infarcts, it does not come back, okay? So interruption of cerebral blood flow, may result from several things, and let's talk about these. The first one is thrombus. Remember what the word thrombus means? It means a stationary blood clot. So let's talk about that. So we could have atherosclerosis, and right here we have a fatty streak or whatever, and you could end up with a blood clot forming over this, okay? And so as it starts to form, and those little platelet guys come floating around, and they start making more blood clot, you can end up occluding it to where blood cannot get through to this side where the brain is, okay? And so that is the example of a thrombus. This can happen for a variety of reasons, but another way this can happen, let me just draw this out for you, is you can end up with a chunk of blood just launching off from inside the heart called like atrial fibrillation, where the top of the heart just quivers. And so then especially like the left atrium, It can just pop out and then go up to the brain. And this happens fairly often. And so when this happens, you'll end up with a stroke. Okay. The other way this can happen is arterial rupture. So if this is like the blood vessels in the brain, what happens is we can get ballooning, just like in the abdomen in a AAA, you can get ballooning of these vessels. And as these vessels balloon, the walls become weak, just like a water hose, right? If I were to balloon a water hose up, it could eventually rupture. And when these do rupture, they bleed. And when they bleed in the confined space of the brain, you present with neurological symptoms, right? So arterial rupture, or the, I just described an aneurysm rupture. That's one way this can happen. And an aneurysm is part of an artery. Okay, sorry. The other way this can happen too is a vessel could just straight up like rupture. Whoops. It could just straight up rupture. Okay, and if it ruptures, of course, it's going to bleed. So I'll recapitulate. An aneurysm is a ballooning of an artery, and that could certainly rupture. That's an arterial rupture, or the vessel could just straight up blow up. Okay, what's the risk factor for this? Uncontrolled hypertension. Okay, followed by smoking and diabetes, and high stress, and a few other things, but that's the main ones. And then a cerebral embolism. And really, this one I described up here is more of an embolism. So I'm not on my game today. So let's draw the heart, right? So this is the heart. Up here in the left atrium, you can have a blood clot that'll form up here from an irregular heartbeat called atrial fibrillation. Okay, pretty common in the population. And so what happens is when the top of the heart's just quivering, it's not actually pumping. And so since it's not actually pumping, blood up there will get kind of shaken up and it'll form a clot because it's just sitting there getting shaken. And so as it gets shaken, it was a thrombus when it was a clot, it'll travel. And as it travels, it can form into an embolism. Remember, a blood clot that is stationary is called a thrombus. A blood clot that is traveling is called an embolism. Okay? And as this embolism travels, it can become lodged. And when it becomes lodged, that will also create a stroke. So the example I gave here up here earlier, that was really an example of embolism, not a thrombus. My apologies. The one before that was a thrombus. Okay? Now, let me delete all my cartoons on here and let's talk about this graph because it's important to understand. Now this graph, don't panic. I know everyone freaks out about graphs. But basically, you can end up with a stroke, and this will present in kind of two different patterns. And so the first one's called an ischemic stroke. Remember ischemia, cells are dying or they're starving for oxygen, okay? And then they'll infarct, okay? And this one is ischemic in nature, and this one is ischemic in nature, okay? And so if you have a thrombus or a cerebral embolism that launches off in the brain, it's just going to block off that area of the brain. So what happens is, let's say, boom, it launched off, it's clogging up the brain. Oh, wow, they're getting symptoms. Well, now the area is just, that whole area that relies on that vessel has died. And once it's died, it just stays dead. So what you see is a plateau. So this is the patient that has sudden onset left-sided hemiparalysis and facial droop and, slurred speech, and they just don't get better or worse. It just stays that way. Okay? That's what typically happens. This is the most common way we see stroke. About 80% of cases will present that way. And that's an ischemic stroke, right? So again, the vessel has been clogged up by something. Okay, the vessel didn't blow up or anything, but the vessel's been clogged. And so now that area that relies on that vessel is going to die. And when it dies, it just dies. Doesn't really get better or worse, it just dies. That's an ischemic stroke. So you tend to see this plateau, right? Like you see this plateau. Okay? And so the other form that this can present is a hemorrhagic stroke. And think about it. If you have a balloon in your vessel, in your artery that explodes, right? Your heart's going to keep pumping blood into the brain. And as it's doing that, since this vessel has exploded, you're going to keep pumping blood on top of the brain where it's not supposed to be. And so your symptoms are going to get worse and worse and worse and worse until you die. And so what we see with a hemorrhagic stroke is someone who just gets worse and worse and worse until they die, right? They never get better. They start having chain Stokes respirations where their brainstem starts herniating. So they start doing that thing where they breathe real fast and then they have periods of apnea, and then they start breathing up fast again and they have periods of apnea, right? That's called chain Stokes respirations. We could also see what's called posturing. So decordicate or decelerate posturing, right? This is part of the Glasgow Coma Scale where we use the GCS, remember, right? So you'll see posturing like this in hemorrhagic stroke, where they can even stretch out their arms like this, right? So we see that in hemorrhagic stroke from brainstem herniation, right? And so the reason that I'm pointing these out is because the treatment for us in the pre-hospital environment doesn't really change, but it's worth knowing, right? So I'll recapitulate this in like 2 sentences. The patient that presents with stroke-like symptoms and their sudden onset and they become bad and they just stay bad, they don't get better or worse, they just stay the same symptoms, right? So left-sided hemiparalysis, that's ischemic in nature. It's usually a blood clot related to some type of blood clot or clot, okay? And then comparatively or opposite, a hemorrhagic stroke is someone who gets worse and worse and worse, and they start posturing, and they start breathing funny, and they're completely unconscious, and then their heart rate starts dropping, right? And they die, right? So the hemorrhagic stroke is very rapidly fatal, okay, because if left untreated. So that's the difference between the two. Hope that makes sense. Now, and I just explained what an ischemic stroke is, so we'll recapitulate, right? An ischemic stroke is a blood vessel that is blocked to the tissue distal to the blockage becomes ischemic. Remember, ischemia comes first and then infarction, so it dies, the brain does not regenerate. So once this area dies, it's gone forever. Can't get it back. So atherosclerosis, remember the whole fatty streak thing, and the way you get the fat up underneath endothelium and the macrophages going in there and the vessel gets smaller, right, in size, right? Atherosclerosis in the blood vessels is often the cause, okay? So remember, atherosclerosis is not confined to just the heart. It could be the brain, it could be your aorta, it could be in your kidney, around your kidneys, right? So it could be a lot of different places, okay? It can be in your legs. So atherosclerosis is all over the body. It's a systemic disease. We just tend to really freak out when it messes with the heart and the brain, okay? Because it creates big problems, okay? Now, in 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 a stroke, like an ischemic stroke, loss of movement on the opposite side of the body is what's common. You can also get confusion and inability to speak, okay? So how does this present? You get loss of symptoms on the opposite side of the body, okay? So let's imagine that I am having a right-sided stroke, okay? So the right side of my brain is dying. This is really weird for people, and it's not fiction. The right side of my brain's dying. Typically, well, let's just say always. There's exceptions to this, but I'm not even going to bore you with that. If my right side of my brain is dying, the left side of my body will show symptoms. Why is that? Okay, let me show you. So we have the brainstem, remember, right? So this is your cerebral. Like I'm looking at someone's head, okay, and then here's the brainstem, right? And it goes down into the spinal cord. What happens is everything feeds in here, and at a certain point, right here in the brainstem, it crosses. So that means like I'm going to draw this in purple. That means the right side of my brain eventually crosses over here in the brainstem, and it goes on and tells my left side of my body what to do. Okay, and the area that happens is the pons, and this thing's called decussation, right? So they decusate, they cross. And so it is true. If you have a right-sided stroke, the left side of your body will show the symptoms. So test question. You arrive on scene and your patient has right-sided hemiparalysis and facial droop, slurred speech. What side of the cerebrum is likely infarcted? If I just said, I think it just says the left side that was symptomatic, it's going to be the right side. It's the opposite, okay? Contralateral. So that's very important to know, okay? And you'll usually end up with confusion, okay? Part of the brain's not working, so that can present with altered mental status, confusion. Also, the inability to speak for several reasons. The first one is the brain's not working, so it takes a lot of coordination to move my mouth and tongue in an organized fashion and process thought to spit it out to you while controlling my breathing and everything. It's very complicated to speak. So you lose portions of that, okay? And depending on how much or little you lose, you end up with jacked up speech. So you'll end up with slurred speech or no speech or repetitive speech or gibberish speech, right? So gibberish could be like, car window highlighter, green, yellow dog, right? Like that's gibberish. So that's all that could also present as a part of a stroke, right? So just be aware that stroke will almost always, not always, but almost always present with hemiparalysis, right? So one side of the body will lose muscle function, and it will almost always present with garbled speech or slurred speech and or confusion, okay? And So cerebral embolism could block the blood flow, and we talked about this. So again, someone has like some weird rhythm where the top of their heart's not beating right, you can launch off a clot from the atrium, go down in the ventricle into the aorta, up into the carotids, and it'll travel up here because these roads get smaller and smaller and smaller. These vessels get smaller and smaller and smaller, and so when it gets so small that the vessel can't or the blood clot can't travel anymore, it just wedges in there, and so the area distal to that will die, and that's a embolism, right? That has formed a stroke. Okay, so remember, embolisms are blood clots that travel. Now, the patient may experience anything from no symptoms to complete paralysis, and this is important. Stroke is on a spectrum, okay, and it really depends on what part of the brain was damaged, past medical history, how big the occlusion is, what type of stroke it is. There's a lot that varies that can determine the severity of a stroke. Okay, so you have to be aware that and, stroke symptoms can come and go. We'll talk about that, but just be aware. Stroke is on a spectrum. Okay. That's ischemic stroke. I want to talk about, yeah, we'll come back. So, yeah, we'll come back. Let's talk about hemorrhagic stroke. So, hemorrhage means to bleed. Okay. So, if someone has a hemorrhagic stroke, they're bleeding within the brain. Okay. Somewhere in the skull, they're bleeding. And so, people at high risk of this are obviously people that have uncontrolled hypertension. Okay. Also, diabetics and smokers, high risk. Stress, high risk. Okay. High cholesterol, but or really not high cholesterol. I'll take that back. But diabetes, smoking, and high blood pressure. Not in that order. It'd go high blood pressure, diabetes, smoking, are at high risk of hemorrhagic stroke. And so this is often fatal because it progresses so quickly, and the treatment for this is usually neurosurgery. And so this is very difficult to fix. Okay, very specialized doctors at very specialized centers will do this. So, for example, in Weatherford, they can't fix this, right? In Fort Worth, the big hospitals can try to fix this, but the majority of Texas doesn't have a neurosurgeon, an interventional neurosurgeon that will go do this. Okay, so this is like going to be in your big cities that these guys are at. So often these patients just die. Okay, and it's a terrible way to die. But the symptoms, what you'll hear them say is they'll have sudden onset headache. So what you see a lot on exams is they'll say like, "Oh, it's the worst headache of my life." Okay, and then so I actually ran a call. It was out of a book, right? The guy told his son it's the worst headache of my life. They're watching a movie. A minute later, he's snoring. A few minutes later, he starts posturing. They call 911. We get there. He's all postured up, right? Decorticate posturing. We intubate the guy. It was a bad deal. He ended up dying. So just realize these rapidly progress, okay? And their symptoms, remember, they get worse and worse and worse and worse and worse until they die, okay? So one thing I'll say about hemorrhagic stroke is it could happen from trauma. I will say that. It can happen from trauma. So think about this. This isn't surprising. If someone hits a baseball bat to your head, you're going to bleed within your skull, and that could cause stroke-like symptoms, okay? Now, we could also have what's called intracranial or your intracranial pressure, okay? So what happens is the cranial vault is confined, right? So the skull is obviously the skull doesn't change shape. And so as the pressure builds up from this leaky vessel, the hemorrhage, it starts building up pressure, and we call that intracranial pressure, okay? And this is also called ICP, right? Intracranial pressure. And so as the pressure will build up, it starts pushing on shit in the brain. And as a general pathology rule, when the brain gets pushed on, it doesn't work, okay? So when you start pushing on the brainstem or pushing on this or pushing on the temporal lobe or whatever, it stops working, okay? Because it doesn't like being compressed. And so that's something to be aware of. And what can happen is, as this pressure builds, it could start pushing on the brainstem. And as it pushes on the brainstem, it starts misbehaving and not working properly, and then it could just completely stop working, and then you die. And so that's an important thing to know, and that's called herniation. Okay? So just like you've probably heard of someone having like an abdominal wall herniation, right? Where the contents of their abdomen can protrude, or a groinal herniation where it can go into the scrotum or whatever. Herniation means to protrude. So what happens is when you have an intracranial herniation, it can happen in different patterns, but the one you got to worry about is a brainstem herniation where it starts pushing up on the brainstem. That one's obviously going to be very fatal. So just be aware. And I just don't memorize what these are. I just put this in here as an example, right? To where, obviously you have this mass, right, above the tentorium. And the tentorium is this like fold of dura mater, right? It's like leather. And so what happens is you can get these certain like patterns of herniation that we don't need to know the names of them, but just know that, as this starts pushing, the brain's it has nowhere to go. So this is like pushing on soft hamburger meat, right? It's gonna have to go somewhere. So it just starts pushing in every direction, and it'll find its way down in there to the foramen magnum, and it will start pushing on the brainstem. Okay. Now they're showing obviously a normal brain, an abnormal brain, right? So tumor, right? So if someone has like a brain tumor, a neoplasia, a neoplasm, that could present with stroke-like symptoms. In fact, it usually will present with a seizure that will look, and then it'll present with the stroke-like symptoms, right? Um, Blood and other cerebrospinal fluid, if it gets compressed, right, for whatever reason, there's a variety of reasons why, that could cause it could cause stroke-like symptoms, or just straight up increase intracranial pressure. There's a lot of reasons why this can happen, right? Um, so it's also abnormal if blood volume increases, like a hematoma, right? Like a subdural hematoma. I'll show you what that looks like. Um, or if there's like and they're talking about the same thing, right? Brain or CSF compression could also cause this shift, and it can also be caused by ICP. And so let me just take your attention to these pictures. What they're showing you here in this one is the brain itself is swelling out, right? And so that's like intracranial, right? Like intraparenchymal bleeds, stuff like that. And then as opposed to this is going to be subdural or like epidural bleeds. Well, not even really. This is more of an epidural, but what I'm saying is the brain itself can be pushed and shifted to one direction. And so what you look at, this is advanced, but what you look at is this thing called the midline, right? So remember, our brain is divided in two, and so it makes this nice, pretty line, and that's what's normal. And what you see in this condition, since the pathology is obviously here, there's something bleeding here, or a tumor or something like that, this line isn't straight anymore. So that's called like a midline shift. So you're obviously gonna have symptoms with this, right? This is major when this happens. And same thing here. Notice this line's not straight, it's curved. That's a midline shift. Okay? Now, we have these things that are like warning strokes. And they're very serious. And they're called transient ischemic attacks. So if you've ever heard the derogatory kind of term for a homeless person, they call them transients, right? Or gypsies or something like that. They call them transients. And so transient means to move or like to come and go, like to move. Like, so homeless people can come and go, gypsies will come and go, whatever, right? And so it means to like be transient, okay? And so a transient, so a stroke that kind of, or something that comes and goes, ischemic, cells are starving for oxygen, attack. So this is an ischemic attack that kind of comes and goes. Okay, that's the layman's definition of it. And what they say is the normal process in the body will destroy a blood clot in the brain. So we can have a stroke, right? We could have this stroke. And if the vessel is small enough, if the clot, is small enough, sometimes our body will go in there and break it up before the area dies, like it fully dies. And so that's called a transient ischemic attack. When your body is able to break up these clots within 24 hours of onset and symptoms resolve, right? That's called a transient ischemic attack, or called a TIA, transient ischemic attack. So the definition of a transient ischemic attack is a stroke that comes and goes within 24 hours. Okay, and so the interesting part of this is the symptoms have to subside as well. So if someone, you're called to their house, you present, they have full left-sided hemiparalysis, slurred speech, confusion, you load them up on the way to the hospital, 10 minutes later, they completely resolve, right? They start talking like normal, they have equal grip strength, their face is no longer drooping, right? You would say, oh, wow, this is probably a transient ischemic attack, but it's still an emergency. We need to go to the hospital quickly, okay? And so that's a transient ischemic attack. And the important part of a transient ischemic attack is 70% of these patients will, if left untreated, 70% of these patients will go on and have a full-blown stroke that does not resolve. So this is kind of like the big red flag. This is a huge warning saying, hey, you need to fix something or else you're going to have another stroke and it's not going to resolve. And you're obviously going to, have deficit from this. So, transient ischemic attack is a stroke that comes and goes in 24 hours and resolves on its own. Okay? Fully resolves on its own. Very serious still. One thing I don't want y'all to do is be like in the field and be like, oh, the patient's symptoms got better. It must be a TIA. Not your job. Okay? This is very complicated diagnosis. And I want you to be aware that stroke symptoms can do something called waxing and waning, right? So like wax on, wax off, right? So like waning, waxing, waning of the moon, right? Comes and goes. So the symptoms can kind of like progress and digress normally. And so it's very complicated to diagnose that. So I just want you to know our jobs as EMTs is to recognize stroke and transport immediately to the appropriate facility. And so what you need to do is realize like, oh, wow, this is a stroke. It doesn't matter if they get better. They still need to go to the hospital right now. This is your big warning sign that the next big one is coming. They need intervention. Okay. They need to see a doctor. Now, what are the signs and symptoms of stroke, right? So there's this, I'll just read these. I'm going to give you a mnemonic, right? So facial droop. So what you'll see is facial droop of the lower face. There's a condition called Bell's palsy, which I'm going to talk about later, called Bell's palsy, where the whole face will droop. That doesn't happen in stroke. In real stroke, just one side of the face will droop, okay? So they'll have like left side of facial droop and their face droops. So how we can test this is you tell the patient to smile and show me all your teeth. And so people, when they smile, they sometimes put on like weak smiles or they don't want to show their teeth. So I'll literally tell the patient, I want you to smile and show me all your teeth and I'll do it for them, Olga. Right? And I'll show them all my teeth. And so what happens if they have a stroke, they'll smile like this, right? And so their face droops, okay? And so facial droop is very common in stroke. And then the next one is they could have numbness or numbness or weakness, okay? And so if they have like left-sided facial droop, they could have left-sided hemiparalysis is the word. Hemi means half, right? So hemiparalysis. And so the left side of their body could be paralyzed. So how we test this, or it'll be weak. It could be paralyzed or weak, right? Hemiplegia or hemiparalysis, right? And so how we test this is we ask the patient to squeeze my hands. So I'll put my fingers in their hands and say squeeze my hands. And what you want to see is that they have equal grip strength on both sides. Okay, so if they squeeze and this side's just real weak, right, on the left side, then I would be like, okay, well that's a positive, right? There's something wrong with that. Okay. They could have decreased or absent movement or sensation on one side of the body. So I want you to realize stroke is not just motor. It could also be sensation, and it usually is, both. Or it could just be sensation. That's complicated. But so stroke could just be sensation. So, we could ask the patient, close your eyes. You would run your fingers down their arms. Do you feel me on both sides, right? And they're going to, or what side did I touch is how you say it. So how you do this test is you say, close your eyes. You run your hands down both arms at the same time. What side did I just touch? If they say, oh, you only touched my right side, even though I just touched both sides, right? That would be a positive that they can't feel the left side of their body, okay? Ataxia or loss of balance. Ataxia means to like stumble. Okay. Loss of coordination is the actual meaning of it. So if someone's like kind of stumbling around like they're drunk, like drunk people are ataxic, right? Or loss of balance, that is a good sign of a stroke as well. Or sudden loss of vision in one eye. So you'll see the patient that can't see out of an affected eye. Or you could also see something called forced gaze deviation or field neglect, right? To where basically they will just look in one direction. Okay, so you're talking to them and they straight on, and they're kind of understanding what you're saying, but they're just looking in one direction. Okay, and so for example, if someone had like right side of facial droop, they'll actually look to the left. They look at the side of infarct, which is interesting, but you don't need to know that. But what I'm just saying is be aware that visual deficits, including oculomotor issues, right? So like forced gaze deficit, just straight up can't see out of that side, or they can have, what's called anonymous hemianopsia, right? To where they can't see out of the right side of both eyes, right? So like if this is God, my writing. If this is the patient's eyes, right? They can't see out of both sides. This is their nose and this is their mouth, right? This is the patient's right. This is the patient's left. They can't see out of both left fields, right? That's called anonymous hemianopsia, right? And that happens quite a bit in stroke. You could also have what's called quadrantopia, right? So you could just have, and we don't really diagnose this in the field. I'm just pointing some things out to you, right? They could just not be able to see out of a quadrant, okay? So there's different ways this can present, okay? Now, dysphagia, you're going to see this on your test, so you need to know this word, means to swallow. And it sounds very similar to this other word called dysphagia with an S, which means slurred speech or messed up speech. So when you see the word dysphagia with a G, I want you to think gulp, right? Like you're swallowing your drink, which I actually need. Dysphagia with a G means to gulp, to swallow. And so if someone can't, think about this, if someone can't swallow, we have to be concerned that they can't swallow their spit, or they can't fill back there to where maybe if they vomit, they can't protect their airway. So you have to be worried when people have dysphagia that they can't protect their airway. Okay? Doesn't always mean they can't, but it's something to at least consider. So remember, the word dysphagia with a gulp, with a G, means to gulp, to swallow. So dys means to like poorly do, right? So they're having a hard time swallowing. Excuse me, dysphagia. Decreased level of responsiveness, aphasia. Notice how this one has an S in it for speech, okay? And this one has a G in it for gulp, right? To swallow, okay? So aphasia means to not be able to speak. So slurred speech, we could see that. That would be dysphagia. Sudden or severe headache, confusion, dizziness, coma. Okay, you'll see all of those. So we talked about this. Remember, left-sided cerebral infarct will cause right-sided hip paralysis to the body and probably aphasia, because the majority of speech is actually on the left side, but usually, and most people, it can change. But anyways, right hemisphere problems can cause paralysis of the left side of the body, and the words also can be slurred and hard to understand, right? And that's a different type of aphasia, but it's just know, speech issue, you might think that's a stroke, okay? And so bleeding in the brain is from intracerebral hemorrhage. What causes intracerebral hemorrhage? Typically uncontrolled hypertension will lead to that, okay? Now, let's talk about how we assess this. And we're going to go over with how to specifically do this in tests and run some scenarios. But there's something called, my handwriting, be fast. Okay, well, we'll move this to here. And I should have put this on here for you guys. But so B stands for balance. So remember, the patient will be ataxic, so they'll have poor balance. E will be for eyes, so they could have eye issues, right? So poor sudden changes in vision. Phi will be for facial drop or facial droop, right? So remember, the face can droop. A will be for asymmetry, right? So there's a test we do where we have the patient hold up their hands, palms up. This is called pronator drift. And we're going to, again, we will go over this in class, but where you have the patient close their eyes and hold their hands up. And so basically, if they're having like a left-sided stroke, it's my left side, or I'll do it on my right side. So basically, I'll do my left side this side. If they're having left-sided stroke, their arm will droop because it'll have weakness and also could have poor proprioception, but it'll droop. And so that's asymmetry. Again, the face will also droop. Also grip strength, it won't be symmetrical, right? So as the patient, squeeze my fingers, right? Squeeze my hands, and they won't grip real tight on one side, right? So that would be asymmetric. S is speech. Remember, they'll have slurred speech. And T is time. Okay, I will have you know that from the onset of stroke to treatment, it can't be more than 4.5 hours to get the life-saving medication called TPA. Okay, so what does that mean? If someone calls 911, or let's say someone, they're talking to you in a restaurant and boom, they have a stroke, right? It's ischemic stroke, right? So a blood clot. We have a clot busting drug called TPA, right? But the thing about this drug is you have to give it within the first 4.5 hours of symptom onset for it to work. After that, we don't give it. And so, if they're at the restaurant and it takes 10 minutes for EMS to get there, and it takes us another 10 minutes on scene, and it takes 40 minutes to get them to the hospital, boom, we're an hour into this, okay? And then it takes another 30 minutes to get to CT and get a scan of the head and get the drug on, boom, we're an hour and a half into symptom onset. They're having a major stroke at this point. But we need to give this drug. So then you give this drug as long as it's within the first 4.5 hours of symptom onset, or what they call last known well, then you're safe and you can go ahead and give it. And what it does is it goes in there and it'll chew away at this clot, and hopefully it'll chew enough at that clot to allow blood flow to go back to that ischemic and infarcted area. Okay. Now, conditions similar to stroke is hypoglycemia. And I'll actually say something that's fairly similar, conditions similar to hypoglycemia is alcohol, right? ETOH, right? So if someone, has low blood sugar, you should be basically, let me put it this way. If you think someone's having a stroke, you need to check their blood sugar. There was this story at an unnamed agency where these paramedics and the flight crew flew a stroke patient, and on the way to the hospital in air, right? The patient, they've already lifted off with this patient. They check the patient's blood sugar and it's like 22. What's the normal range? Somewhere between 70 and 120. It's like 22. And so they give the patient glucose through the IV and the patient wakes up, right? Totally fine, no stroke. And they land at the closest hospital. So can you imagine the embarrassment and the $25,000 bill for that, right? That's negligence. So just be aware that anytime you suspect stroke or altered mental status, you need to check a patient's blood sugar always, because hypoglycemia causes a lot of weird neurological deficits. And so all stroke patients check their glucose always, always. And most commonly, it's hypo, meaning low blood sugar less than 70, that will present with stroke-like symptoms. Okay. The postictal state, we're going to talk about this on the coming slides, but postictal state is after a seizure. Someone just ran a marathon and their brain's really tired, so it's kind of messed up for a period of time, 5 to 10 minutes, and that can present like they've had a stroke. Okay, so the postictal state is the state after a seizure, a grand mal seizure, a tonic-clonic seizure. Okay, and again, a subdural or epidural bleeding, I would venture to say these are still stroke because they present with stroke-like symptoms. But if you get very technical, someone could argue that they're not. I'm not going to test you on the difference between the two, but we've talked about this. I will say an epidural hematoma is common, and how this will present is someone gets punched or struck in the temporal lobe. This part of your brain, the temporal lobe, is very thin. The bone here is called the pterion, and you can also see right here, there's several sutures that take place here, right? Several parts of the skull join right there. And so it's very thin. It's the thinnest part of the skull. And so if you get punched there, there's this huge artery that runs up underneath there called the middle meningeal artery. You see that? It can get snapped by that broken bone. And basically it'll bleed on top of the dura. So on top of epidural hematoma. So you get a bruise on top of the dura mater, which is the meninges. And so this presents with a set of signs and symptoms that's pretty deadly, right? You die really quickly from this if it's not treated. And then like a subdural hematoma, this is different. You actually see this in shaken baby syndrome and in like alcoholics and older people even that have brain atrophy where their brain shrinks. What happens is as we age, our brain shrinks, okay? And so there's these, I think I've discussed this before with y'all. There's these things called bridging veins that connect the layers. And so if someone falls and smacks their head, those bridging veins can tear. And when they tear, they create venous bleeding up underneath the dura, but on top of the pia mater. And so what happens is you'll end up with I'm sorry, on top of the ractum mater. No, yeah, on top of the ractum mater. And so what happens is you'll end up with a slow insidious bleed. So I will say for a subdural bleed, right? This usually takes place over like hours to days. So the classic vignette on this is someone who fell and hit their head 3 days ago in the shower. They were fine, and this morning they wake up with stroke-like symptoms. Well, you need to be thinking like, oh, this could very well be a subdural hematoma. And so where I'm getting at with these is you need to be careful with patients that have a history of trauma. They can present with stroke-like symptoms, okay? And these are life-threatening. So they need surgery usually. Not always, but usually. And so, and it's, I kind of jump ahead sometimes, but the subdural bleed and the epidural bleed usually result from trauma. I just said that. The onset of stroke-like signs and symptoms may be subtle. So epidural hematomas, since it's an artery that's bleeding, these tend to be a lot quicker. And so I just put this picture in here. You can appreciate that the brain is thin here, or the skull is thin here, and it's the bone broke, and you have some swelling, soft tissue swelling here. But you end up with this like big bleed in here, and you can even see a little bit of what's starting to be a midline shift here, right? Like this isn't just a straight line through here, okay? So that's an epidural bleed. Remember, that's someone who gets punched typically right here in the temporal lobe of the skull. And this is a subdural bleed. It's a different pattern. It usually, this is a more fresh one. That's an old one. But basically, it usually, this can be from shaken baby syndrome. Some old person with a smaller brain or an alcoholic even that has brain atrophy can fall and smack their head and be venous bleeding up underneath the skull, up underneath the dura mater, okay? So obviously you're not expected to read CTs. I just put these on here to hopefully illustrate it to where it makes sense what I'm trying to say. Sometimes pictures can help, okay? I've made up my mind. I'm going to make this 2 lectures because seizures takes a while, and then we're going to talk about a few other disorders and assessments. So let's stop here, take a quick break, and then we'll make this 2 videos. Okay, thanks. Bye.